Leg and foot numbness and tingling is a very common problem. If the leg and foot numbness and tingling is in just one of your legs, then there are 6 most common causes of those symptoms, and we're going to talk about each of them as well as how to treat each of those causes in just one moment. Now, if the leg numbness and tingling is in both of your legs and or the feet, then there's a not so lucky 7th cause that we'll be discussing as well. And finally, we're going to talk about an exciting diagnostic twist at the end of this video. And this twist is going to have very important clinical implications that you won't want to miss, whether you're a patient or if you're a doctor. So please stay tuned for that. Hello, I'm Dr. Grant Cooper at Princeton Spine and Joint Center. Now, when you think of diagnosing and then treating leg and or foot numbness and tingling, the first thing to recognize is that numbness and tingling are clear symptoms of nerve irritation. So if you're having these symptoms, then somewhere in your body, your nerves are upset. Now we can figure out where your nerves have gone wrong by exploring the most common patterns that nerves go wrong in. And what we'll see is that in the legs and the feet, it almost always comes down to one of 7 causes. If the numbness and tingling is confined to the bottom of the foot, then that's in the distribution of the posterior tibial nerve. Now there are 3 common problems that can lead to symptoms in the posterior tibial nerve distribution. The most common is actually a pinched nerve in the back. If someone has an S1 radiculopathy or inflammation around the S1 nerve root as it exits the spine, then this can cause pain, numbness, and or tingling radiating down the back of the leg and into the foot. It can, however, skip the buttocks and thigh and even skip the lower leg completely and just present as numbness and tingling in the bottom of the foot. If you have a pinched or inflamed S1 nerve root, then treatment generally begins with targeted exercise to support the spine. See, the reason that exercises for your back work so well when they're done correctly is that your spine relies on the muscles, tendons, and ligaments that attach to it in order to support it. It's like this. If you take your spine out of your body and you place it on the ground, your spine could support about a 35-pound axial load before it would start to break up. Now, no matter how thin you may or may not be, you weigh more than 35 pounds. We all do. So we all rely on our muscles to support our spine. In this way, our spine is like a mast on a sailboat. A mast on a sailboat, if it just stood there with nothing attaching to it, it would fall over because it wouldn't be able to support its own weight. And that's why if you look at a sailboat, there's all that rigging that attaches to the mast. The rigging supports the mast, and in the same way, our muscles attach to our spine to support our spine. So, back to the S1 pinched nerve. If we can get our muscles to do a better job of supporting our spine, then that can take the pressure off of the nerve root and allow the nerve root to heal. Now, these exercises often involve core strengthening, hip flexor stretching, hamstring stretching, thoracic and lumbar spine mobility exercises, as well as other exercises that will be specific to you in order to make sure you have no muscular imbalances. We have a great video on back pain exercises, and we'll be sure to put a link in the description of that video if you want to check it out later. If physical therapy isn't helping enough, then sometimes an epidural steroid injection will be used to reduce the inflammation and the swelling from around the nerve root. An epidural steroid injection can reduce the inflammation and the swelling, which in turn can reduce or eliminate the symptoms. But of course, an epidural is not changing the underlying biomechanics, so if an epidural steroid injection is used, then it should always be used as a window of opportunity so that while the inflammation is gone, you can focus on the correct exercises in order to tweak the biomechanics enough so that the inflammation does not ever return. If symptoms persist despite aggressive conservative care, then sometimes a surgical decompression of the nerve root is needed in order to mechanically decompress the nerve. Now, other times, the spine may need to be decompressed and fused as well in order to stabilize that segment of the spine. Now, there are other alternative treatments as well that are often worth considering, and these would include most notably acupuncture as well as gentle chiropractic care. Ideally, these alternative treatments can be used as part of a more comprehensive conservative care plan. For me, no matter what treatment plan is utilized, even if someone ultimately needs surgery, exercises alongside and on the back end of that treatment should always be planned on in order to improve the biomechanics and make it less likely that someone develops a similar spinal problem or any spinal problem for that matter in the future. The next most common cause of symptoms in the bottom of the foot is irritation of the tibial division of the sciatic nerve as it passes through or around the piriformis muscle in the buttocks. Usually with sciatica, the pain will be in the buttock and radiate down the back of the leg into the foot. Sometimes, however, it will just present with numbness and tingling in the bottom of the foot. Treating true sciatica, that is compression of the sciatic nerve, often involves physical therapy in order to use soft tissue mobilization on the piriformis muscle and teach the patient exercises that he or she can then do in order to stretch the piriformis muscle and the surrounding muscles, as well as to strengthen the piriformis and the surrounding muscles. Nerve glides are often quite helpful with sciatica as well. Now, occasionally, an injection called a sciatic nerve block can be done in order to reduce the inflammation from around the nerve. Of note, when nerve blocks are done, they should always be performed under ultrasound guidance, both for safety as well as to make sure that the medication in the nerve block is placed in the optimal location. A trigger point injection into the piriformis muscle, which is often in spasm in true sciatica, can be helpful as well. Now, surgical release of the sciatic nerve can also be done. It's uncommon, but it can be performed by releasing a portion of the piriformis muscle. The third most common cause of symptoms in the bottom of the foot is when the posterior tibial nerve is inflamed and or compressed inside of the tarsal tunnel. This is what is known as tarsal tunnel syndrome. You've probably heard of carpal tunnel syndrome. Carpal tunnel syndrome is an entrapment of the median nerve in the wrist, and it's the most common peripheral nerve entrapment in the human body. Tarsal tunnel syndrome is the most common peripheral nerve entrapment in the lower leg. Tarsal tunnel syndrome is more common in people with flat feet and who wear shoes with poor support. Tarsal tunnel syndrome symptoms are generally worse after you've been on your feet for a long time, because when you stand, you tend to put mechanical pressure on the tarsal tunnel itself. This pressure is worse if you have flat feet or if you have mechanics that predispose to your ankle rolling inwards onto the tunnel, which of course in turn puts more pressure on the posterior tibial nerve, which is inside of the tunnel. Now, this is why one of the first line treatments for tarsal tunnel syndrome, if you do have flat feet, which is also known as hyperpronation, is a good orthotic in your shoe in order to help restore the arch and therefore take the pressure off of the tunnel. If an orthotic is not helpful or not helpful enough, then there are other good treatment options. Physical therapy is one conservative measure that can be very helpful for tarsal tunnel syndrome in conjunction with an orthotic. Physical therapy will focus on strengthening the intrinsic foot muscles as well as the muscles around the ankle in order to help support the arch and stabilize the ankle. Now, physical therapy will also utilize passive modalities such as soft tissue mobilization to reduce swelling and increase mobilization in and around the tunnel, as well as nerve glides to specifically break any adhesions, increase mobility, and reduce swelling around the posterior tibial nerve in particular. An ultrasound-guided steroid injection is sometimes used to treat moderate or severe tarsal tunnel syndrome. The injection reduces the swelling and the inflammation in the tarsal tunnel, which then takes the pressure off of the posterior tibial nerve. It's important that if you use an injection to take away the inflammation, that you also use better footwear, orthotics, and exercises in order to address the biomechanics after the injection has alleviated the inflammation. Finally, it's rare, but sometimes surgery is needed to decompress the tarsal tunnel in order to release the pressure on the posterior tibial nerve inside of the tunnel. This is called a tarsal tunnel release, and it involves releasing the flexor retinaculum and a septum that compartmentalizes the medial and the lateral plantar nerves and the overlying fascia of the abductor hallucis muscle. If the symptoms are in the lateral aspect of the lower leg and or in the top of the foot, then this is in the distribution of the peroneal nerve. When someone has numbness and tingling and or pain in the lateral aspect of the lower leg and or the top of the foot, then this is also usually due to one of three causes. I just need to pause very briefly and make a request of you. If you're enjoying this content and if you're learning something useful, please go ahead and press the like button as it helps us with our YouTube algorithm. And also please subscribe to our channel. Thank you very much. The most common cause of symptoms in the lateral aspect of the lower leg and or in the top of the foot, once again, is from the spine. If someone has an L5 pinched nerve in the back, then this will often present with back pain and buttock pain and pain radiating down the leg and into the top of the foot. However, sometimes it will present with only numbness, tingling, and or pain in the top of the foot. One would treat an L5 pinched nerve in the same way as an S1 pinched nerve, with exercises, physical therapy, sometimes an injection, at times alternative treatments such as acupuncture and gentle chiropractic care, and occasionally with surgery. The second most common cause of numbness and tingling in the lateral aspect of the lower leg and or in the top of the foot, once again, is compression and irritation of the sciatic nerve as it passes through or around the piriformis muscle. This is an interesting point about the sciatic nerve that you might not have known. The sciatic nerve has two divisions of it. It has a peroneal division and a tibial division that together form the sciatic nerve. Now, if the tibial division is affected, as we discussed before, then the symptoms will occur in the bottom of the foot. But if the peroneal division is affected, and the peroneal division is the more common division of the sciatic nerve to be affected, because the peroneal division has a more lateral position, and this actually makes it more vulnerable to injury. Now, if the peroneal division of the sciatic nerve is affected, then the symptoms will be in the lateral aspect of the lower leg and or the top of the foot. Treatment for compression or irritation of the peroneal division of the sciatic nerve is going to be the same as for treatment of the tibial division of the sciatic nerve. Now, namely, this will mean exercises, physical therapy, occasionally ultrasound-guided nerve blocks or trigger point injection, and very rarely surgical release. Now, to give a sense of how rare surgical release of the sciatic nerve would or perhaps should be, let me offer my own clinical perspective. I've been seeing patients with these types of symptoms for 2 decades, and I've literally never had a patient go for a sciatic nerve surgical release. On top of that, when I was at Columbia University Hospital, Cornell, Hospital for Special Surgery, and in our own group here at Princeton Spine and Joint Center, I've never met a colleague who told me they have sent a patient for surgical release of the sciatic nerve, and no one has ever presented about such a patient in a ground rounds or in journal club. Now, this is definitely not to say that it's never necessary, but it's rare because almost all patients with sciatic compression get better with conservative care. Now, again, some patients will need a surgical release, but my point is just that the overwhelming majority will get better with good conservative care. The third most common cause of numbness and tingling in the lateral aspect of the lower leg and or the top of the foot is a compression of the peroneal nerve itself. The peroneal nerve passes around the fibular head beneath the knee at the top of the lower leg. As it does this, the peroneal nerve passes close to the surface of the leg and is therefore very vulnerable to compression. For any of my martial artists out there, when you see fighters throwing lower leg kicks, they're targeting the peroneal nerve in their opponent. If they can hit the peroneal nerve, the nerve suffers an injury and their opponent temporarily loses their ability to dorsiflex or lift up their foot. Basically, they're trying to give their opponent a foot drop, and it's very hard to move when you're dealing with a foot drop. Now, this happened to Jimmy Crute in his fight against Anthony Smith. It happened to Henry Cejudo, Triple C, in his title fight against Demetrius Johnson, and it also happened to Conor McGregor when he fought Dustin Poirier. More commonly, the reason that someone develops a peroneal nerve injury at the fibular head is if they had a cast on that wasn't fitting quite properly, and then that cast was putting pressure on the nerve. Now also, if someone's been lying down a lot and they happen to be putting pressure on the nerve by the position of their leg, then this is a common cause for it as well. This is something that doctors are, or at least should be, on the lookout for in the hospital when patients are in bed for extended periods of time. Now, other risk factors would include wearing high boots and also crossing your legs regularly, which can also end up with repeated pressure being placed on the nerve. Treating a peroneal nerve entrapment at the fibular head first involves removing the offending problem. So, if a cast is putting pressure on the nerve, adjust the cast. If a person is crossing their legs and putting pressure on the nerve that way, don't do that. If the person is wearing high boots that puts pressure on the nerve that way, it's time for some new boots. If there's a cyst that's compressing the nerve, then the cyst should be drained, popped, or otherwise surgically removed. Once the offending problem is gone, often it just takes some time for the symptoms to resolve. Physical therapy can be helpful to speed recovery. Nerve glides and soft tissue mobilization can be helpful. If there's a foot drop, then certainly therapy will be helpful in building up that muscle again. Now, if the numbness and or tingling symptoms are in both of your feet in a fairly symmetric pattern, then this may be a symptom of what we would call a peripheral neuropathy. A peripheral neuropathy is another way of saying that there's a generalized problem with the nerves. Peripheral neuropathy symptoms often show up first in the toes and the feet. This is because the nerves to the toes and the feet are the longest peripheral nerves in the body and are therefore also the most vulnerable. You could think of a peripheral neuropathy as similar to wear and tear of the nerves or wear and tear of any other structure in the body, such as the joints. And indeed, about half of all the peripheral neuropathies don't actually have an identifiable cause. We call those neuropathies idiopathic. Now, someday we may be able to identify an underlying cause for those neuropathies, but for now we tend to think of them as akin to wear and tear of the nerves. The most common type of peripheral neuropathy that we can diagnose with a clear cause, that's a peripheral neuropathy where we know why it's happening, and the one that many people think of when they hear about a peripheral neuropathy is a diabetic peripheral neuropathy. When someone has uncontrolled or poorly controlled diabetes for many years, the nerves can become affected and start to not work properly. And we find that about half of people with diabetes do in fact have some form of nerve damage. There are many other causes of peripheral neuropathies. In fact, whole books are devoted to the many other causes. Now, some of the more common causes include low vitamin B12, thyroid problems, low folate, smoking, infections such as Lyme disease, HIV, chronic kidney disease, certain types of cancer, a history of certain kinds of chemotherapy, and a host of other potential problems. Basically though, for our purposes right now, if you have numbness and tingling in both of your feet, and if those symptoms are symmetric, and if those symptoms don't change regardless of what you're doing, for example, if the symptoms don't get particularly better or worse with sitting or standing or walking, then a peripheral neuropathy is very high on the list of potential diagnoses. On the other hand, if you have bilateral numbness and tingling in your feet that gets worse when you walk and goes away when you sit, then a peripheral neuropathy would remain on the differential diagnosis list as a possible cause. But spinal stenosis, where the nerves are being impinged in the spine, is much more likely, since when you stand, the symptoms are worst, suggesting they're being impinged when you stand, and when you sit, the symptoms go away, suggesting that with spinal flexion, the pressure is taken off of the nerves in the spine. This mechanical nature of the symptoms is much more consistent with a spinal cause than with a generalized problem of the nerves. The first step to treating a peripheral neuropathy once it's diagnosed is to search for a reversible cause. If the person has a diabetic neuropathy, then of course we should try and control the blood sugars better. If the person has a low vitamin B12 or folate, then we can supplement those. If the person's found to have a thyroid problem, then we can treat the thyroid. If there's an infection, then we must treat the infection. If the person is a smoker, then we must counsel them to stop smoking, and so on and so forth. Sometimes a peripheral neuropathy is identified, but a reversible underlying cause is not found. In these cases, we must treat the symptoms. Now, this often means supplements and medications. Supplements would include alpha-lipoic acid, curcumin, and omega-3 fatty acids. Lots of people reach for vitamin B supplements when they have nerve issues, but you do have to be careful. Too much vitamin B6 can actually cause a neuropathy, so be careful. In general, if you don't have a vitamin B deficiency, then supplementing with more vitamin B will be unlikely to make a big difference, and you definitely don't want to take too much B6. Prescription medications include gabapentin and pregabalin, also known as Neurontin and Lyrica, which are nerve membrane stabilizers. Tricyclic antidepressants and selective serotonin and norepinephrine reuptake inhibitors are also used. As a general rule, medications work better on pain, burning, and tingling, and they work less well on numbness. Now, we need to talk about the important diagnostic twist that I teased at the beginning of this video. It's so important because it gets overlooked way too often. If you've watched some of my other videos, you may already know what I'm about to say, because I try to talk about this a lot because that's just how important it is. This thing that we need to talk about is something called double crush syndrome. In double crush syndrome, there are two compressions of a nerve along the same nerve chain. So it's sort of like a river that's being partially blocked at two spots along its course, and as a result, the water at the end of the river is going much slower. So for example, perhaps the S1 nerve is inflamed in the lower back. The S1 nerve branches off and ultimately feeds the posterior tibial nerve that goes through the tarsal tunnel in the ankle and then enters the bottom of the foot. In double crush syndrome, the S1 nerve may be inflamed and the patient may also have tarsal tunnel syndrome. So the nerve is then getting hit at two distinct places. Now this is very important to identify because failing to identify both problems may lead to wrong or simply inadequate treatments. An example here will illustrate the point well. Now, I have so many examples to choose from when talking about double crush syndrome, which again is why it's so important that patients and doctors keep this problem in their collective minds. I had a patient a while ago that had been treated by a podiatrist for pain and tingling in the bottom of the foot. Now, this patient had been given orthotics, physical therapy, injections, and medications, and the symptoms would always get a little better, but they would never completely go away. Now, this went on for about a year. The treating podiatrist wanted to surgically release the tarsal tunnel of this patient. The patient wanted to avoid surgery if at all possible, so he went for a second opinion from another podiatrist. Now, that second podiatrist thought that maybe there was something else going on and maybe it wasn't just tarsal tunnel syndrome, so he sent that patient to me. And when he came to me, with the benefit of hindsight, I ordered an electrodiagnostic study, also known as an EMG. Now, the EMG showed mild tarsal tunnel syndrome and also a moderate S1 pinched nerve. So I then got an MRI of his lumbar spine, and sure enough, the MRI showed a big disc herniation at L5-S1 compressing the S1 nerve root. So I then performed an epidural at the S1 nerve root level, and the symptoms went away completely. In this patient, it wasn't that he didn't have tarsal tunnel syndrome. He did, but he also had a pinched nerve in his back. And if he had gone for that tarsal tunnel surgery, the surgery wouldn't have helped because the tarsal tunnel syndrome had already been adequately treated. The remaining symptoms that the patient was getting was coming from the S1 pinched nerve. There's another story that I'd like to relate. And again, if you've heard me speak of this one before, then I apologize for the repetition, but it's so important simply because it gets overlooked so often. Now, this one comes from my training when I was working as a resident at Memorial Sloan Kettering in New York City, which you may know is a famous cancer hospital. Now, many of the patients that we saw had nerve symptoms, and they'd been diagnosed with chemotherapy-induced neuropathies. So they were being sent to us for basically symptom management. The thing about chemotherapy-induced neuropathies is that all you can really do is treat the symptoms with medications or maybe supplements, but we didn't have a good way of treating the underlying chemotherapy injury to the nerves themselves. But what we found at that time at Sloan Kettering, and we saw it over and over, was that patients with a chemotherapy-induced neuropathy, with symptoms in their feet, for example, sometimes also had tarsal tunnel syndrome. The tarsal tunnel syndrome may have been mild, but when it was superimposed on the chemotherapy-induced neuropathy, it ended up with bad symptoms for the patient. Now, we couldn't fix the chemotherapy neuropathy, but we could fix the tarsal tunnel syndrome. And once we had treated the tarsal tunnel syndrome, the symptoms usually got much better, even if they didn't totally go away. The important take-home point is that for so many of these patients, the doctors had stopped at the diagnosis of a chemotherapy-induced neuropathy, and they just hadn't thought to look for anything else. Now, there was indeed a chemotherapy-induced neuropathy for those patients, but if they had also found a pinched nerve in their spine, or sciatic, or tarsal tunnel syndrome, or carpal tunnel syndrome for that matter, or some other nerve issue that we could fix, then by fixing what we could fix, we could vastly improve the symptoms and vastly improve the patient's quality of life, which is what we were really after for them in the end. But again, you have to think to look for those things and not stop at that first diagnosis. This is one of the reasons why when someone has nerve symptoms, and particularly if surgery is being contemplated, it's often helpful and advisable to get an electrodiagnostic study or EMG first. In this study, the nerves are traced out in order to see where the problem or problems are. I hope you found this video on diagnosis and treatment of leg and foot numbness and tingling useful. And if you've enjoyed it, and if you've learned something, then again, please remember to like this video to help us with our YouTube algorithm. Also, please subscribe to the channel and tell a friend who might enjoy this as well, because that's the way that we can spread good health information and achieve good health outcomes together. Now, as always, if you have suggestions for future videos, or if you have any questions or comments for me, then please leave a message in the comment section. Thank you very much. Importantly, the person doing the test has to consider the presence of double crush syndrome. My colleagues and I have seen too many EMGs where the doctor saw tarsal tunnel syndrome or peripheral neuropathy and then just ended the test and never interrogated the nerves in the lumbosacral spine to see if there was also a pinched nerve in the back, for example. Now, as always, if you don't consider a problem, you won't look for it. And if you don't look for it, you can't find it even when it's right in front of you, and that can and will lead to poor outcomes. I hope you found this video on diagnosis and treatment of leg and foot numbness and tingling useful. And if you've enjoyed it, and if you've learned something, then again, please remember to like this video to help us with our YouTube algorithm. Also, please subscribe to the channel and tell a friend who might enjoy this as well, because that's the way that we can spread good health information and achieve good health outcomes together. Now, as always, if you have suggestions for future videos, or if you have any questions or comments for me, then please leave a message in the comment section. Thank you very much.